Good morning, ladies and gentlemen, and welcome to day 2 of the 5th International Summit on Waldenstrom's macroglobulinemia. I'm pleased to report to you that the workshop has concluded, and we had a very, very successful meeting. And as I had mentioned to you, 364 delegates from 31 countries. It was an absolute record. And more importantly, you know, when we contrast against the first international workshop, you know, so much growth has occurred. I was telling folks last night, when we first started, we had 16 people meeting in Bethesda, Maryland. And we were in a government building, you know, at the NIH, and Bruce Chesson had hosted us. And we got up in the morning, and I think one of the things you recognize is that doctors need their coffee in the morning if they're going to be helpful, right? I think we all do, but doctors in particular. And so we're sitting in this room around a table, and we were all watching this coffee maker that they had. It was one of those government-issued coffee makers. And drip, 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 you know, 16 people keeping an eye on, you know, hoping that at least, you know, there'd be a cupful, you know, that maybe could be passed around. But metaphorically, as I was telling folks last night, this really represented the way things were for Waldenstrom's. As we were watching that coffee maker, we were also realizing this is what we were facing. We were getting drips of information, but we could never get to the point of having a full cup. And now, when you look at what has been learned and continues to be learned, it's astonishing that even in 3 days, starting our meetings at 7:30 in the morning, you know, as we did, we still, you know, just barely managed to get all the material in. And in fact, many times we couldn't even get questions in because, you know, there was just so much data. That's really for us something to get all fired up and excited about, because it's showing us the exponential growth that's happening in our ability to, you know, learn about Waldenstrom's macroglobulinemia. And what has changed is that, you know, we're not borrowing ideas now from other diseases, we're creating our own. And in fact, quite the opposite, we're now exporting ideas and, you know, benefiting those who are researching other diseases that are particularly impacted by the mutations that, you know, have been discovered in Waldenstrom's, like the MYD88. So, you know, the tables have turned. Today is going to be a particularly exciting day because you're going to see now how our knowledge of the therapeutics that we use in Waldenstrom's has evolved. We really will have some great lectures, and importantly, these will be given by stellar people who are tops in their field. So we're going to start off this morning, we're going to talk about the proteasome-inhibitors. And to lead this particular session and all that's been learned, you know, here at the workshop will be 2 extraordinary people, both of whom really are tremendous experts, giants in our field. Stathis Kastritis works with Thanos Demopoulos. He is a faculty member at the University of Athens and has made tremendous contributions to the literature in this disease. I really regard him as one of the great giants who continues to grow and really represents the future of this disease. And he will be joined by another wonderful friend and colleague, Dr. MJ Kersten, who is a professor at the University of Amsterdam. And she was actually the organizer for the 9th International Workshop on Waldenstrom's, which took place in Amsterdam 2 years ago. It seems honestly like yesterday, but it really was one of the greatest meetings that we had, and we're so proud to have both of them here today to be able to lead this first session. So please help us welcome both Dr. Kersten and Dr. Kastritis.
Well, thank you, Steve, for those kind words. Let me see how I can start this presentation. Yes, that's it, right? I learned. So it's a great honor for me to be here at the Patient Doctor Summit here in New York. And as Steve said, we organized the last workshop in Amsterdam. And I recognize some of you because some of you even made it all the way to Amsterdam, which was a great pleasure for me. So today, together with Stathis, we will discuss the role of proteasome-inhibitors in the treatment of Waldenström's, and I will just give a brief introduction on what is actually the proteasome and why are proteasome-inhibitors, why can they be effective in this disease. Actually, this is also a little bit of a home game for me because I spent a year as a postdoc at Sloan Kettering, but that was already about 20 years ago, I must say. But it's great to be back in the city. So these are my disclosures. The study that we performed was financially supported by Takeda and Roche and the Dutch Cancer Society, and I also received research funding from other companies. So what about the proteasome? Who of you knows actually what the proteasome is? I was wondering. No, so I'll explain a little bit about what it is. Actually, the proteasome is sort of like a little factory in the cell, and it's important for protein degradation. So in the cell, lots of proteins are made, but they have to be degraded, otherwise the cell gets cluttered up with all this garbage, and that's not good for the cell survival. So, but also it's important for for sort of targeted degradation, because in the cell proteins are present, but they're not active because they're, for example, coupled to an inactivator. And once they're degraded by the proteasome, they do become active. So it has a sort of a regulatory function as well. And why is it important in Waldenström's and especially also in multiple myeloma? Well, as you know, one of the hallmarks of these diseases is that the cells produce enormous amount of proteins, you know, the M protein. And if all that, you know, gets built up in the cell, it's an enormous stress for the cell, and the cells sort of explode. So you need the proteasome to get rid of those proteins. They're also secreted, but they're also degraded by the proteasome. So what happens if there's no proteasome, the proteasome is inhibited by drugs, then it's like there's no garbage collection in New York City or Amsterdam, and will become a big mess. And as I said, for example, this is maybe a little bit complicated slide, but NF-kappa B you should remember because it's a very important protein in the cell. It actually gets activated by the MYD88 mutation. So activation by MYD88 ultimately leads to NF-kappa B activation. And if the protein NF-kappa B is activated, the cells are proliferate, they're protected against dying, and they do all sorts of things that will help them survive. So if you inhibit the proteasome, there's no active NF-kappa B, and the cells are going to die easier. So the rationale to use proteasome inhibitors is actually then twofold. There is high production of proteins in these cells, which leads to stress if they're not degraded. And there's high NF-kappa B activation because of the MYD88 mutation. So that's why proteasome inhibitors in particular are active drugs in this disease. And they also induce, you will see later, rapid responses. So there's a couple of proteasome inhibitors in the clinic. There's Bortezomib, which is sort of the old drug by now. It was the first proteasome inhibitor in the clinic. It was first given intravenously, but now you can also give it subcutaneously. It acts very fast, so if, for example, patients have renal failure, it's one of the drugs that we prefer to give because it gives such a rapid decrease in the M protein and the light chains. In myeloma, it's also good for bone disease, but its one major drawback is that it gives neuropathy. And there's successors, and we'll talk about that, such as Carfilzomib and Ixazomib. And they have a couple of other side effects, such as thrombocytopenia, low platelet counts, and also herpes zoster shingles is a complication, and some patients have diarrhea. So I'll give the microphone to Stathis, who will talk about Bortezomib and Carfilzomib. Thank you.
Good morning. I'm very happy to be here with you. I'm coming from Athens, Greece. That is, as you know, far, far away. But it's my first time in a patient summit, and you are so many here. Oh, that's fantastic. So this is actually an old study. And the importance of presenting data from old studies is that you know what really happens after 2, 3, 4, 5, 8 years. This study is it's more than 10 years than we started. This study started in 2007. That's 11 years. So we know very well now what happens when you give this combination in patients with Waldenström's that did not have any prior therapy. As Marie-José told you, Bortezomib is a relatively old drug, and at that time it was given as an IV push. Now we give that drug subcutaneously. This has made a significant change in terms of toxicity, but not in terms of efficacy. So some of the toxicities that we see here may be better with the new formulations. Now, this was a prospective study in which we enrolled 59 patients from several centers across Europe. As you know, there is a problem for those patients that have very high levels of IgM. When you give rituximab in these patients, then there is a risk that the IgM levels may rise, and we have this flare phenomenon, and then they go down. But when they rise, they may cause additional problems. So that is why we thought that if we give Bortezomib before rituximab, we give 4 infusions of Bortezomib before rituximab, because this drug is very active, can reduce the IgM levels, and then we can start adding rituximab and avoid the IgM flare phenomenon. It's a strategy. Also, in order to reduce the toxicities that we know that Bortezomib has, we decided to give Bortezomib every week and not 2 times per week. Also, it's more convenient. And as I told you, it was given as an IV push, but now we use it subcutaneously. Now, there was no maintenance phase, and maintenance means that we didn't continue with some type of therapy after the completion of the planned initial therapy. So the whole duration of this therapy was 23 weeks, which is not very long. This is the regimen. As you can see, there is the initial, let's say, induction phase with Bortezomib only, just to reduce the IgM levels, and then we added also rituximab and a small dose of dexamethasone, mostly to avoid the infusion-related reactions that are associated with rituximab. Also, at that time, rituximab was given IV. Now, in the past years, we use rituximab subcutaneously. So this regimen that initially made one thing that, it takes time, 6-7 hours with rituximab, IV push. Now it's much more convenient because in 5 minutes you also can have your rituximab and your Bortezomib infusion, so it's much, much better. As I told you, 59 patients were recruited in this phase 2 study. It took quite a long to recruit the patients, but now we have a minimum follow-up for living patients that is more than 6 years, and the median follow-up of this study is probably 8 to 9 years. This is a mature study, and this is very important. As you can see here, many of the patients that were enrolled in this study were above the age of 65. This is very important. So actually, many of the patients were above the age of 75. Many of the patients had hyperviscosity syndrome, meaning that they already had high levels of IgM. As you can see, 44% had IgM levels above 4,000. And the disposition, according to the risk stratification system IPSSWM, 85% of the patients were intermediate or high risk. So these were patients that really needed therapy, and they needed immediate resolution of their symptoms. Now, this was a very effective regimen. As you can see, the overall response rate was 85%, including the minor responses, and major responses were 68%. Major responses means that the IgM was reduced by at least 50%, and minor is between 25% and 50%. This took some time. As you can see, median time to initial response was about 3 months, and to the time to the best response was 6 months. So what we also saw is that even after completing therapy, we still had improvements in IgM levels. So patients continued to have reductions on their IgM levels even after 2, 3, 4, and 6 months after they completed therapy. Now, the progression-free survival is 43 months, which is 3.5 years. With the current standards, may be considered like not tremendously good, or we're not very enthusiastic. However, it is very important to remember that after 7 years, 1 out of 4 patients still remains in remission. And also, progression-free survival is a complicated measure of outcome. What happens for those patients who achieved at least a partial response that reduced by 50% their paraprotein? As you can see, the progression-free survival was 51 months, and the median duration of response, meaning that many of these patients never required further therapy and didn't have any relapse, was 80 months. So actually, many of the patients that responded continued to be in remission for more than 6 or 7 years after 23 weeks of therapy. Now, 40 patients progressed at the time of last follow-up. 22 received second-line treatment. Not all patients that have a rise in IgM, as you know, need therapy immediately, but progression-free survival captures any type of progression. So it's kind of biased in this aspect. So the median time to next treatment was 73 months, and almost 90% of the patients that were retreated, mostly with regimens containing rituximab, responded again. So it's a regimen that gives you also the opportunity to retreat with the same drugs. The overall survival at 8 years was 66%, and this is a population with a median age of 68. So it's not really bad. And I think what is also important is that at the time of last follow-up, as you can see, half of the patients died because of Waldenström's, but half of the patients that died because of something else. And this was an elderly population, so it is important to note that we can fight Waldenström's very effectively, but there are also other things that we have to take care of after we win our battle with Waldenström's. And regarding toxicity, as Marie-José told you, Bortezomib is a neurotoxic drug. So maybe this is not a very good regimen for someone who has neuropathy because of Waldenström's or has neuropathy because of diabetes. And in many patients, we had to reduce the dose or discontinue therapy. Nowadays that we use sub-Q Bortezomib, this may be a little better. We also had some pulmonary toxicity, but this was, it's quite unusual with Bortezomib in other diseases like in myeloma, but we saw 3 patients, all of them of which continued therapy after we gave them therapy for the pulmonary toxicity. Regarding long-term complications, because we have to remember that when we treat Waldenström's, we want to have a long remission, but also to have a long life without additional problems, without additional complications. We didn't have any cases of myelodysplasia, and we had 3 patients that transformed their disease to more aggressive lymphomas, and 2 patients who died from solid tumors. So later in the afternoon, we will have the opportunity to discuss about what can we do for these solid tumors that are also a problem. Now, we'll also present some data that Steve Trion in Dana-Farber has generated regarding another proteasome inhibitor that is called Carfilzomib. This is, let's say, it's a second-generation proteasome inhibitor that has certain advantages over Bortezomib and certain disadvantages. So this was a phase 2 study in patients that had not received prior therapy, or at least they didn't have received either rituximab or bortezomib. It's a more complicated regimen because carfilzomib has to be given intravenously. It's given 2 consecutive days per week. In this regimen here in CARDI, it was not given every week, but it was given every 2 weeks, every 3 weeks. It's a little different than in myeloma. But this may be a problem for many patients. At least in our practice, it is a problem if the patient has to come 2 consecutive days a week, especially if it's working or is busy or needs support to come to the hospital. Another issue with carfilzomib is that, at least in patients with myeloma, is associated with some risk of cardiotoxicity. So for patients that already have some cardiac problems, may not be a very good option. On the other hand, carfilzomib is very effective and is not associated with neurotoxicity. So for patients who have issues like peripheral neuropathy because of Waldenstrom's or other causes, may be a very good option. These are the patients that participated in this study, 26 patients, of which 17 also continued in the maintenance phase of the study. And as you can see, the responses were again high, 81%, with 71% of the patients achieving, let's say, major responses, at least 50% reduction of the paraprotein. You can see here how rapid was the reduction of the IgM levels, and also the improvement in hemoglobin and hematocrit, indicating how effective this regimen was. And as you can see, regarding toxicity, it is very important that significant peripheral neuropathy did not exist. There was some minor peripheral neuropathy, but what we call grade 3 neuropathy, which is significant, actually did not exist. But as I said, there were some issues with cardiomyopathy and fatigue, etc. The progression-free survival, as you can see, it's 58 months. This is a study that also contains some maintenance. And compared to BDR, with median progression-free survival for responding patients of 66 months, we can say that we have 2 proteasome inhibitors that if we combine with rituximab, we can have a very long remission of the disease, and we can choose between 2 drugs that have different profiles of toxicity, so we can adapt to the needs of the patient. And then we go to some data that were presented also for carfilzomib from Dr. Vezole. And in this case, carfilzomib was given in very few patients, 7 patients. What is very impressive in this study is that carfilzomib was given in a very high dose as a single agent in patients that were mostly refractory, and the response rates were very high, actually were impressive. It was almost 90% in patients, many of which, 3 out of 7 were refractory to bortezomib. So this is very interesting, the fact that this drug is very safe at these doses. These doses in myeloma, we don't even imagine. It's more than double than the doses that we use. And also, this led us to start a study in Europe in which we combine carfilzomib with ibrutinib in order to achieve very deep and rapid responses in patients with Waldenstrom's. And now Marie-José will come to continue with the 3rd proteasome inhibitor, because we have a lot of choices. We go from the IV and sub-Q to oral proteasome inhibitors.
Thank you. Yeah, we won't do it like idols that you get to choose which one you like best. So the rationale for treatment with Ixazomib, which is a novel oral proteasome inhibitor, is obviously that it's easy to use because it's a pill every week. So also attractive in the elderly population, I would say, and there's also a low rate of neuropathy. And as has been shown by Steve and Jorge Castillo, it's effective in first-line Waldenström's. And this was already published recently. It was a prospective trial in 30 patients where you could see a rapid or more or less rapid decrease in the IgM levels, which was paralleled by an increase in the hemoglobin levels with relatively low toxicity. And also here there's a relatively short follow-up, but there's a good amount of patients that have that are progression-free for a couple of years. So we did a HOVON study in the Netherlands together with the Greek myeloma group with Stathis and Dr. Dimopoulos, and also Belgian centers participated. And it was a study in 60 patients with relapsed Waldenström's. And we gave 8 cycles with Ixazomib, Rituximab, and Dexamethasone. So the Ixazomib is given orally, as is the Dexamethasone, and the Rituximab is given sub-Q, which makes it a very feasible regimen. And in these patients, we were also interested to see whether with Rituximab maintenance we could prolong the progression-free survival. So the main inclusion criteria for the trial are patients who have a relapse and of course have a need for treatment, because if the IgM is increasing a little bit, it's sometimes better to just wait and see. And the patients could have prior Bortezomib or Rituximab, but they shouldn't be refractory to it. And exclusion criteria were the very rare Bing-Neill syndrome or amyloidosis and known intolerance to one of these agents. So basically, when we started the study, there was no evidence yet in Waldenström's patients. So we looked at what was a safe dose, and that we took to the phase 2 study. And for the phase 2 study, we wanted to know what was the response rate for this combination. But also, of course, we wanted to see what is the toxicity and how long do these responses last. And also, is there indeed an improvement of the response when you give Rituximab maintenance during 2 years? So this was a patient population with a median age of 70. And most of the patients had high or intermediate risk when you look at the IPSS risk score. So when we studied with the phase 1 study was with 6 patients with the dose that is also used in multiple myeloma, 4 milligrams, and it was also safe in Waldenström's. And then we did the rest of the study with this dose, and today I present the interim analysis of the first 29 patients. And actually for almost none of the patients we had to do a dose reduction, so it was a feasible dose. And 24 out of the 29 patients completed the whole treatment. And as you can see, it's actually rather similar to the data presented by Dr. Kastritis. The overall response rate, again, was about 80%, so that seems to be a little bit common for all these drugs, with a sizable amount of partial and very good partial responses. And as you can see here, the IgM levels decreased and the hemoglobin levels increased, as they should. So this is with relatively short follow-up because it's an ongoing study. Median follow-up is 18 months. There were 2 patients actually who died during the trial. One patient had a brain infection, but going back to this case specifically, the patient already had signs and symptoms of this infection going on the trial. We think it was related actually to the prior therapy. And one patient who was very unresponsive to any medication also did not respond to the Ixazomib. The patient went on to an allogeneic stem cell transplantation with a transplant from an unrelated donor, and the patient sadly died from graft versus host disease. So there were no treatment-related deaths. And there was relatively few toxicity, which was mostly infections, and no grade 3 neuropathy or grade 2 with pain. So I think Ixazomib is a feasible and active regimen, both in first line and in relapse patients. We currently are looking for 7 more patients to complete the study. It's a high ease of administration because it's oral, and we think it's a good backbone to combine this drug also with other drugs such as BTK inhibitors like ibrutinib or venetoclax, which you will hear more about shortly. So actually, if you look at the field of treatment of Waldenström's, we are very lucky that there are so many more drugs that are now coming to the field, and it's of course it always takes longer than we and especially you hope before we can have these drugs in the clinic. But it's very important that we do these clinical trials to prove that they're active and safe to use. And in Europe, we have decided to join forces, and this is something that was done under the leadership also of Dr. Dimopoulos and Dr. Buske. We formed a European consortium for Waldenström's macroglobulinemia, and the main goal was to collaborate, and we also collaborate, of course, with the US and Australia. It's not just a European sort of party. But the goal is to have international cross-border clinical trials, but also we aim to make guidelines for the treatment, and we aim to do translational research because that's very important to understand why some patients do and some patients don't respond to certain therapies, so that maybe in the future we will have more personalized treatment. And within this consortium, we were already able to do several studies, one of which is the HOFON study that I just showed you, but also a randomized study which was just completed, where it was randomized between immunochemotherapy, the DRC regimen, plus or minus Bortezomib, the proteasome-inhibitor, and that study has now fully accrued. We don't have the results yet, and currently we're going to do a study with Bortezomib and ibrutinib. And also there will be a next large phase 3 study that should start in mid-2019, where the combination of Carfilzomib and, just like Dr. Kastritis said, the combination of Carfilzomib and ibrutinib will be tested. So, in conclusion, I would say that proteasome-inhibitors are important drugs in the treatment of Waldenström's, and they can be combined with rituximab and dexamethasone and then have a high response rate of around 80%. The newer proteasome-inhibitors are less neurotoxic, and also Bortezomib, when you give it sub-Q, is less neurotoxic. And they can be combined as well with the other novel drugs, such as the BTK inhibitors or venetoclax. And those will be or are currently in clinical trials. And I would say here also the collaboration is the key to success, because there are many drugs and many combinations, and we cannot do everything at the same time. But if the WM treating doctors and centers collaborate better together, we will be able to do so much more. But most importantly, I think the collaboration between patients and doctors is very important, and that's why we are here today and why I'm so happy to see all of you here at the summit. So I would like to thank you for your attention. We're happy to take questions.
I'm curious, just a quick question. When you use these subcutaneously, is it for home use with a device, or do they come in and they're treated under supervision?
Yeah, so it depends. So it can be done at the hospital, but we also do it at home. It's done by specialized nurses who also check for neuropathy and do a questionnaire, and they administer it at home. Yeah, but it can also be done in the hospital. I don't know in Greece.
You don't need a special device. It's very easy to administer the drug sub-Q.
So can the patients just administer it themselves, like an insulin pen, or do they have to have some supervision?
Well, if they are very well educated, it's still a drug. It's not chemotherapy, but still it's a drug that may have toxicity, so you need to be careful. But I think we had, for example, patients that were doctors or nurses, and they could administer by themselves. The injection is very easy. It's like insulin. Mm-hmm.
I notice in many of these regimens that you're using dexamethasone. Is that additive to the anti-cancer effect, or could you substitute Benadryl if it's strictly to prevent an infusion reaction from rituximab?
Yeah. Yeah, that's a very good question, and actually we're looking at that right now because dexamethasone has some activity, as in myeloma, also for Waldenstrom's. But in the newer trials, and also in the trial that we will do in the consortium, we will give a proteasome-inhibitor and ibrutinib and no dexamethasone. Because of course the side effects of or a little bit of dexamethasone, the side effects are of course also considerable. Yeah.
And I think that our general approach now is to reduce the doses of dexamethasone to the minimum required for safety reasons regarding the infusion-related reactions.
Yeah. Yes, please.
Thank you very much. Pete Skinner, I was on the Ixazomib trial at Dana-Farber and saw a very good response, but at the last 2 months, that response turned into a disaster where my lungs filled with fluid, and I had to be pumped every week. I noticed your slide said something about pulmonary toxicity. Is that unique to these proteasome inhibitors? I'm now on venetoclax. Should I expect that as an outcome of my venetoclax trial?
Yeah. So you saw, but it was pneumonitis.
The type of pulmonary toxicity that we show, it wasn't fluid in the lungs, but it was more like an inflammation in between in the lungs. So it was, let's say, like allergic reaction that improved very fast with low doses of steroids, and the patients could continue on therapy. So this type of reaction that you have is probably something different. This is something that we have seen also with other proteasome inhibitors, this lung reaction, this allergic reaction.
So, in other words, you think it's unique to the proteasome inhibitors?
To proteasome inhibitors mostly.
Thanks.
Good morning. Since the proteasome exists in every cell in the body, can you explain why it doesn't have a wider impact on healthy cells, the inhibition process?
Yeah, that's again an excellent question. That's actually what I thought when we first embarked on treatment with proteasome inhibitors. Why doesn't every cell, blow up or get killed? But it doesn't. So I think some of it is the increased sensitivity of the cells because of their protein production. They're under so much more stress for the proteasome and the plasmatic reticulum. But actually, we don't know. Yeah.
Okay. And a second question. Shingles is known as a possible risk here.
Yeah.
Do you think that the new Shingrix vaccine is sufficient to protect, or would it be better for people to be on like valacyclovir?
Yeah, so it's not sufficient in every patient, as you know. So if the patients are not vaccinated, then we advise valacyclovir prophylaxis.
Okay, great. Thank you.
If I may add something to your first question and the response that Marie-José gave, proteasome is very important for all of us to stay young. And we are doing a lot of research in our department and with colleagues in Athens who started by studying proteasome in order to make drugs to reduce the effects of age. So when we give proteasome inhibitors, actually we cause, let's say, a little bit of aging. But our healthy cells can restore proteasome activity very fast, but cells that are very dependent on proteasome, they cannot sustain their living even with a small amount of inhibition. So many of the creams that we use for the faces, they actually activate proteasome, and they're good for the wrinkles.
So we have to give cream, or we shouldn't give cream. Thank you.
I wondered if in your trials, if you differentiate those patients who do or do not have the MYD88 gene?
So for the old trials, so when we started the trial with Bortezomib, we didn't know anything about MYD88. So we don't have data on how patients with mutation or non-mutation in MYD88 do in terms of response and duration of the response. We are trying now to collect the data to see retrospectively how they did. We go back to archived material to identify whether the mutation was there or not. So there are some data from Jorge Castillo's work and Steve's work on Carfilzomib and Ixazomib that there may be, for patients who are CXCR4 mutated, there may be a delay in response, but overall there are not differences in responses in terms of duration of response.
Yeah, and so that's where the collaboration becomes important, because that's where we should pool the data from, because all the studies are relatively small, but if we pool the data from all the studies together, we can hopefully answer those questions. But at the moment, for the next large trial, that we will stratify for mutation. So that will be the first study where we actually do it prospectively. But every patient gets a drug, but we look prospectively whether or not they have the mutation. For the older trials, we just have to go back and do it. That's a very good question.
Hi.
Hi.
Yeah, Mitch Orphis. I have it's specific, but also a general question for all trials at this stage in the state of the art. And I was wondering if every trial patient now is genome sequenced, so that when you get to the end of it, when it's 80 months out, can you go back and you find out that this group of people did very well, and this group of people didn't do so well? You could then predict for future people who should and shouldn't be put on that regimen.
Yeah.
Well, we don't genome sequence all the patients that we have, but we do, and it's in almost every trial, is that we have ancillary studies, and one of the concerns that we ask is to store biologic material for future use. For example, maybe in 1 or 2 in 3 years, we have a new technique that can, analyze the genome in 1 day and very cheap, and then we can,
Right, for 20 cents. Right.
Yes.
Yeah.
Or have a technique that can analyze the genome in 20 selected cells. We have to have material. This is very important. So that is, we ask the consent from the patients to store the biologic material.
Because, the averages are always a little disappointing.
Absolutely.
Because it doesn't tell you much.
No, it would be great if you could predict for the response to therapy.
But it's just too expensive now to do that.
Well, it's too expensive, and it's not as black and white always. So, for example, even for ibrutinib, if you have the CXCR4 mutation, you are less likely to have a deep response, and it may take longer. But it's not that none of the patients with CXCR4 mutation respond. So it's not that black and white always.
Thank you.
But I think it's very important to, as Stathis said, we should definitely do it. Yeah, absolutely.
Thank you.
How frequently do you see a reaction during infusion, such as chills and such, during the...
With the Bortezomib?
With Bortezomib, with which drug? With Rituximab? With any of the drugs?
With any of the drugs or alone?
So with Bortezomib is not it's very uncommon. With Carfilzomib is also not very common. Maybe in 10-15% of the patients. That's why we use a very low dose of dexamethasone to avoid this. With Rituximab, with IV infusion, maybe 15, 20, 25% of the patients have reactions like chills, fever,
during the infusion.
During the infusion, yes.
Thank you.
Yeah, and the problem with rituximab, especially in Waldenstrom's, you probably have the same experience that usually it's only during the first infusion, but in Waldenstrom patients it can get worse in next infusions, and that can be a problem. But our experience with the subcutaneous rituximab is very promising, that we don't see the reactions.
No, we don't have any issues.
Yeah. And yeah.
What are the specific cardiac toxicities with these drugs?
Well, Carfilzomib is the drug that has mostly been associated with cardiac toxicity. What we see is a reversible reduction of the ejection fraction, meaning how the heart pumps the blood. It's a reversible reaction. It's something that we have seen in many patients with myeloma. Probably is associated with pre-existing cardiac disease. The important thing is that it is reversible. So we stop the drug, and the cardiac function comes back to normal, and then we can again restart the drug at the lower dose. This is our strategy, at least in patients with with myeloma. With the other drugs, there are some issues, with Bortezomib, especially when we were using it as an IV push infusion, we had seen some atrial fibrillation, not very often, but it was something that we had seen.
Yeah, and in addition, you also see some hypertension and hyperlipidemia, so that's things that you should follow in these patients, yeah.
If you had a very minor response to Bortezomib with Rituximab, are these other Carfilzomib and Ixazomib potentials, or are they?
Well, in patients who have not had very good response to Bortezomib, I'm not sure that by switching to Ixazomib we could have a better response. We don't have such data, but I don't think that we could do this switch. These two drugs are very similar. Now, we have the data regarding Carfilzomib at very high doses. These doses, it's not the ones that we usually use, showing that even patients with refractoriness to Bortezomib can respond to high dose of Carfilzomib. But this study was in 7 patients, so I think we have to be very careful for the doses and the results.
Okay, if there are no more questions, thank you very much for your attention.